Move ahead a little bit then. Yeah, hello. Welcome everybody. Good morning for those on the West Coast. Good afternoon for those on the East Coast. My name is Ryan Melton, and I am the Clinical Director for the ESAS Center for Excellence, one of the co-hosts of this presentation this morning. I have the honor and privilege to introduce our speaker, which is Dr. Barbara Walsh, coordinator for the Prime Clinic at Yale University School of Medicine. She oversees the clinical evaluation and treatment performed on young people at the clinic and is responsible for providing psychoeducation on the early warning signs of serious mental illness in young people to a wide variety of communities. She's also responsible for training professionals here in the United States and abroad on the proper use of the assessment instruments used to diagnose the early warning signs of serious mental illness. She first co-authored the book, The Psychosis-Risk Syndrome, which is the topic of today's talk. Handbook for Diagnosis and Follow-Up. With that, I turn it over to Barbara Walsh. Welcome, Barbara, and thank you.
Thank you very much, Ryan, and welcome everyone. I hope we're going to be able to give you some really good information about this early identification work today. And let's just start with really very basics. Psychological and emotional difficulties are like any other medical problem. Early signs and symptoms occur before serious illness develops. And just like with any medical illness, the sooner we can identify those problems, the sooner we can treat them, the less likely they are to interfere in that person's day-to-day functioning, and more importantly, less likely to impact their quality of life. Going to talk about the phase first as the prodromal phase. I am very aware with the advent of the DSM-5, people are no longer using the prodromal phase, but you will see prodrome in some of my slides. And the way that I decided which word to use was based on what was used at the time the research was published. So you will see prodromal phase. You certainly will see Psychosis-Risk Syndrome, or PRS. You'll also see clinical high risk, CHR, ultra high risk, UHR, and at-risk mental state, ARMS, or the very general phrase, which is called pre-psychotic. It is very clearly defined as the period between the most valid estimates of when things started to change for the young person. So when they started to depart from their normal level of functioning and presentation to the point where they became fully psychotic. The important thing to remember about this phase in mental illness is that it is fluid and evolving. It is not a stagnant phase in mental health. It changes, and a lot of times people will ask me, how do you differentiate between an autism spectrum disorder and a prodromal disorder? And one of the things, it's not the only thing, but one of the things is you will see in the prodromal phase that it is very fluid and changing as opposed to long-standing and stable. The most vulnerable age period is 12 to 25. The median age of onset for first episode psychosis is 19, and 85% of people who are going to develop psychosis have it by the time they're 35 years old. During this phase, there is a decline in functioning and the beginning of mild but not yet fully psychotic symptoms. So again, it can be conceptualized as the earliest form of psychosis. It can also be conceptualized as a heightened vulnerability to becoming psychotic, but that doesn't necessarily invariably lead to psychosis, but does cause the patient distress and interference in their day-to-day functioning. CHR patients are very clear. I'm not myself. This isn't me. Something's changing. They're upset by it. They're help-seeking. Please help me. I want this to stop. And they're in need of treatment whether they go on to develop psychosis or not. They're in need of treatment for that level of distress and interference that they're experiencing in their life. There's been tons and tons of research about this at-risk phase, and I certainly do not mean to represent all of it that's done because I could never touch on everything. But just to give you a summary of some of the most relevant research, the Australians really were the very first ones to do this. And they opened a FEP, first episode clinic, and some people presented at the clinic that didn't meet criteria for full-blown psychosis. And the Australians were smart enough to say, let's follow these people anyway. Let's see what happens when we're monitoring them in this early phase. And what they found is if they were there to intervene within 28 days of these young people crossing from the at-risk phase to the fully psychotic phase, those people did better, not just short-term, but even years later, they were doing better than their counterparts who didn't get that early intervention and identification. And so the Norwegians got on board with the TIPS project, and what they tried to answer the question was, is it possible to reduce the duration of untreated psychosis because it appears to be so important to the prognosis for these young patients. And what they did is they launched a major psychoeducation campaign. There are sectors in Norway instead of states. And in one sector they did early detection, ED, and in the other sectors they continued with usual detection, UD. And what they found in that sector where they launched that psychoeducation campaign, they were able to reduce the duration of untreated psychosis from approximately 2 years down to 19 weeks, which was very substantial. And then the Brits got on board, and they said, well, if it's really important to reduce this duration of untreated psychosis, can we take it perhaps back one step further? Can we identify people before they cross that threshold to full-blown psychosis? And they also launched a psychoeducation campaign, but Norway's was targeted mostly at professionals who worked with young people. And the Brits changed it up a little bit, and they educated the general population. So flyers were mailed to every home. It was in the newspapers. It was on the radio. It was on the TV. It was in the movie theaters. And they were able to significantly reduce the new incidences of psychosis in any given calendar year. And that became really, really important and led us to believe it was possible to identify people in a pre-psychotic state. And that led to PACE and TOPS and the PRIME data that really began to focus very heavily on this at-risk phase. And while we're talking about the phases of a psychotic disorder, most typical course of a phase will have the prodromal phase or at-risk phase, the acute phase where someone is actively psychotic, and then the recovery phase. Now, not every person is going to go through all of these phases exactly the same. Certainly, each person's experiences will differ. and they may have longer periods of the prodrome, shorter periods, longer periods of the acute phase. It can be different for everybody. And, you know, this concept of the prodromal phase or the at-risk phase is nothing new in medical health. It's been around for ages, but it did appear to be a new concept in mental health. And probably easy examples of a prodromal phase of a medical illness is measles. Measles usually starts out with a 3 to 4 day prodromal period characterized by fever and a cough, and then that very significant rash develops. And when that rash develops, that's the point that the accurate diagnosis can be made. Diabetes is another example. If you go to your doctor and have a fasting blood sugar and it's over 100, you're going to be diagnosed as a diabetic. But from, you know, ages of working with diabetic patients, doctors recognize the prodromal or at-risk phase. It's called metabolic syndrome. And that's where a person is perhaps overweight, perhaps sedentary, has maybe high triglycerides. And the doctor will recognize that they are at higher risk for developing diabetes. And of course, they don't want to sit and wait until that person develops diabetes because of the risks of all the blindness, neuropathy, and everything else. So they're going to start treating that person in that at-risk phase. Now, are they going to treat them immediately with insulin? No, of course. You start with the least invasive form of treatment. So in the case of diabetes, perhaps a change in lifestyle, diet, and exercise. But you don't just want to ignore those early warning signs. And the prodrome in the psychotic disorders is also defined as a heterogeneous group of behaviors that are temporally related to the onset of psychosis. And so there's many different ways that people define this particular phase of the illness. The prodrome literally comes from the Greek word meaning it's prodromus, which simply means forerunner. And when the work groups were gathering to work on the DSM-5, a lot of people in the field weren't comfortable with that word because of the forerunner nature of it. They felt that definitively implied that people were going to become fully psychotic. And we know that's not true. We know there's only a certain percentage that do go on to become fully psychotic. The other thing is the length of the prodrome can vary. It can last from several months to 1 to 2 years. The highest risk for conversion to psychosis is within those first 2 years, but prodromes have been recorded that lasted as long as 10 years. And some of the interesting studies and research work that's going on in first episode psychosis is trying to gather data about 0% GUP and how that impacts the course of the illness and people's prognosis. More recent, this again isn't anything really new in mental health, although we refer to it as being new. It was truly first addressed in 1938 by Dr. Cameron, and he basically said there was a need for a preventive approach to schizophrenia, and he called for detection of a very early disorder to prevent later serious ill health. And he was really talking about, even if you couldn't prevent transition to psychosis, could you mitigate how severe the psychosis would be? More recent authors have also stressed the importance of early diagnosis and management to reduce or prevent the additional psychological and social problems that result from having psychosis. So it's not just about preventing psychosis, but it's about preventing all the disability that accompanies it. And it is believed that the longer the duration of prodromal symptoms, that is indicative of a poorer prognosis for the patient. But it's certainly an area that needs to continue to be researched. Let's just quickly take a look at the various phases of schizophrenia or psychotic illness. And that first pre-morbid phase, typically people fall into two categories. Pretty normally functioning young people going to school, having friends, being engaged in activities and interests. And what their parents describe is, it's like my child's hit a wall. All of a sudden my child is not my child anymore. And as you can imagine, that's very devastating for the parents. But there's also another group of young people in that pre-morbid phase, and those are those young people who have typically been a bit off-center for their whole life. Everybody knew something wasn't quite right, but diagnostically, there wasn't any one diagnosis that explained the whole picture. And unfortunately, in the past, what some clinicians had to do was just wait. Wait until that young person developed more severe symptoms that met diagnostic criteria. And that wasn't the best option, needless to say. So now we have this new at-risk phase that people are working with, where there is a decrease in functioning. There are beginning of mild but not yet floridly psychotic symptoms. So these young people recognize something's changing, something's different, but they maintain the insight of what is real and what isn't. So they haven't quite lost contact with reality. And then you'll see on here where the yellow frame meets the blue frame, that, excuse me, that's where night changes into day, so to speak, okay? It's where a person goes from being pre-psychotic or at risk to becoming floridly psychotic. And then that low point in the blue section is where that young person gets the first appropriate treatment for psychosis. Now, it isn't necessarily the first time they've ever been in treatment for mental health issues, but it's the first time it's treatment appropriate for a psychotic spectrum disorder. And believe it or not, that line from the onset of the illness to first appropriate treatment, which is defined as the duration of untreated psychosis, on average is about a 2-year period of time. So these young people are walking around unsure whether what they're perceiving, what they're thinking, what they're feeling, seeing, hearing. They have no clue whether it's real or it's not. And of course, we're sending them off to school and expecting them to learn and do well socially with all of this going on. It's very, very debilitating for these young people. Now you see, once they do get appropriate treatment, they do rebound, but they don't rebound to that pre-morbid level of functioning that you see in the first pre-morbid phase. The whole point of early identification is really twofold. Number one, to capture them while they're still in that yellow phase so that they don't ever have to get as bad as where they're down for a first appropriate treatment. And secondly, if you catch them in that yellow phase, when they rebound, they're going to get much closer to their premorbid level of functioning and therefore have a better, not only prognosis, but better quality of life. And I've been very fortunate. I've been here at the Prime Clinic for over 19 years now, and I really had the honor of working with a large group of young people who were in elementary school. And I was able to follow them for over 10 years and watch the progression of their illness. And not this past September, but the September before that, a large group of these young people that I was working with went away to college. Now, it might not have been the level of college that they aspired to before they became ill, but they were able to regroup and get that experience and therefore have that improved quality of life. This list is a list of some of the behaviors of concern that we look for in young people. Now, if you are experienced working with young people, I'm sure you're chuckling at me right now because I defy you to find me an adolescent who doesn't have some of this going on. But there are really some specifics to it. Number one, you want to identify changes. And again, this goes back to the fact that the prodrome is fluid or unraveling as opposed to long-standing and stable. And you would certainly want to identify more than one behavior of concern on that checklist. And most importantly, there has to be either a level of distress on the patient's part for the symptoms, or there has to be an interference with their functioning. What do I mean by that? Let me give you a quick example. I had a young woman who came in for a SIPS, and she would periodically see two people, one a male, one a female. They were kind of ethereal, not fully formed. She knew they weren't real, but they would happen to her. She couldn't control it. It was very distracting. It was distressing to her, and she really wanted help to make those people go away. As opposed to another young girl that I had seen for a SIPS who explained to me that when she sat at the kitchen table in her home, she would have a tactile illusion of a cold wave coming over her. And when I asked her how she accounted for that, she said that she thought it was the ghost of her dead grandmother and that her dead grandmother was coming to comfort her. She wasn't the least bit distressed by it. In fact, she welcomed it. She loved it. But what started to happen is she started sitting at the kitchen table waiting for Grandma to come instead of going to school or being social with her friends. So it began to interfere with her day-to-day functioning. There are some very specific early warning signs of psychosis in young people. Increased difficulty at school or work certainly is one, and I don't mean I was a freshman last year and now I'm a sophomore and so the work is harder and I'm struggling. What I mean is the same work that I could do a month ago, I can no longer tolerate, and I just can't seem to handle it. You're going to find that these young people withdraw from their family and their friends. They have a lot of noise going on in their head. They are afraid for people to find out about this. So what do? Better I not spend a lot of time with you and you'll catch on to what I'm experiencing. Better I just stay away from you so you won't figure it out. Probably the most common complaint that I hear during a SIPS evaluation is my friends are not my friends. They are just pretending to be my friends. Or the other thing that I hear a lot from young people is my parents are imposters. It's not my real parents. And so therefore I need to withdraw from them to protect myself. These young people are going to have difficulty concentrating or thinking clearly. they're going to look very, very much like an ADD patient. However, the attention deficits in this particular case are linked to the unraveling of the psychotic process as opposed to ADD or ADHD. And, what I try to explain to parents when I'm explaining the differences to them, you could have a headache today because you forgot your eyeglasses and you have eye strain. Or you could have a headache today because you're very stressed out and your blood pressure is elevated. The symptom, the headache, is exactly the same in both cases. But what's driving that headache is different. And so one of the things that we want to be clear about is understanding what's driving people's symptoms. These young people are certainly going to be suspicious of or mistrustful of others. As I said, they may fear their parents aren't their real parents anymore. Their friends aren't their true friends. The teacher's out to get them. And I don't just mean that the teacher gives a lot of homework or is a hard marker, but they really feel singled out and picked upon by the teacher or the professor. They're going to have changes in the way things look or sound. At-risk patients are hypersensitive to light. Fluorescent lights in schools are very difficult for them. You never want an at-risk patient to be sat next to the window in a classroom where the bright sunlight or movement out there could add to their distraction. Noise they're hypersensitive to noise. What for you or I is a 2 on a volume scale, for them is a 10. And so as they get into middle school and high school and they have to change classes, that becomes particularly difficult for them. They are going to be hypersensitive to that noise. When I go into PPTs, I will say to the teacher, let this young person go 30 seconds before the bell rings. They're not going to miss that much in your classroom, but they'll be able to navigate those halls without the chaos and noise so they can get to their next classroom and attend much sooner. And the teachers are always amazed at how much that little intervention that didn't cost anybody any money, but what a difference it makes in helping that young person to be more successful in school. They also will report that colors are like high definition. Green is, much greener, red is much redder, and that can be sometimes a little bit disorienting for them. These young people are going to have odd thinking or behavior. These are the kids who cannot keep pop culture in check. It just is going to overwhelm them. Back in the day when the Twilight series of books and movies was out, all of my patients were afraid of the woods behind their house because they thought there were werewolves back there. And then the Twilight series was quickly followed by the Hunger Games. And then all my patients were afraid that the government was tracking them and following them. So they just can't seem to rein in pop culture. And I guess there's a new movie out now, Split, and all this week, all of the SIPs that I did, these young people are concerned that they now have multiple personalities. So they really, really struggle with that. And they're going to be into every single form of alternative theories that there are. They're going to be into witchcraft and Satanism and UFOs and any other alternative theory than the world that they're living in right now. In addition to that, these young people are not very good at predicting their social environment. They really misread cues. And that's why very often people look to maybe explain it with an autism spectrum disorder. But typically what happens is this young person, let's say, is walking down the hall in school, and there's 3 of their peers standing on the side. And as they happen to walk by, those peers start laughing. And that young person is like, why are you laughing at me? Why are you making fun of me? And the peers are very confused. They're like, what are you talking about? Our conversation had nothing to do with you. And what happens to this at-risk person is they very quickly realize, I'm not getting this right. I'm embarrassing myself because I'm not reading people right. And so what they try to do is shut down. Better I not show you what I'm feeling than embarrass myself by getting it wrong. So I kind of call it, a poker face. They don't want to show their emotions. Some people refer to it as being a bit wooden, but they're being protective. They don't want to show you how they're reacting emotionally because they're fearful they're going to misread what's going on. And these young people will also have poor personal hygiene. Now, not necessarily in the way that a chronic schizophrenic would, where they're disheveled, there's an odor, but you know what it's like to be an adolescent or a teen. Whatever your group is, you want to fit in. And what happens with these young people is they no longer care. They don't care what clothes they're wearing. They don't care if their hair is washed. They don't care if they have makeup on. They're just less concerned about their personal appearance. It's just not anywhere near as important to them. As we're talking about the early warning signs and trying to put it in that place of the pre-psychotic, psychotic realm, it's very, very important that we recognize psychotic disorders are very truly complex, and they appear to involve multiple susceptibility genes interacting with multiple environmental factors throughout the development of the young person, and that's when they develop the illness. We know it is not just a purely genetic illness. How do we know that? In identical twins who have the exact same DNA, when one twin develops psychosis, only 50% of the time does the other twin. If it was purely genetic, you would have 100% concordance, and we know that's not true. And if this is anything that is of interest to you, Dr. Spiro is a psychiatrist, and she and her twin sister, who is schizophrenic, wrote a very interesting book, Divided Minds, that looks at the illness from both of their perspectives. And I found it very interesting, and if it's of any interest to you, if the genetic piece is of any interest to you, you might find it interesting. There is evidence that schizophrenia is both a neurodevelopmental and a neurodegenerative disorder. So the vulnerability to psychosis originates in the abnormal fetal brain development, and then abnormalities in the adolescent brain development contribute to bring out the onset of this disorder. And it really, puberty is definitely the most vulnerable age period. It also it is tied to the pruning process that occurs during that process of puberty, and then goes on to impact these young people. Some of the possible neurodevelopmental factors could be maternal illness, especially it's been linked to the second trimester of pregnancy, maternal lifestyle, diet, alcohol, drug use, tobacco use, things like that. Complications in pregnancy, high blood pressure, diabetes, problems with the placenta ripping, things like that could contribute. Complications in delivery, the use of forceps, suction, the cord being wrapped around the young person's throat. And then certainly genetic abnormalities could be a contributing factor here. Q22 deletion has certainly been linked to psychosis. Possible environmental factors and neurodegenerative factors are certainly the hormones and the process of puberty. One of the things that the Naples 3 study is looking at is the impact of cortisol, the hormone that is how we perceive and manage stress, and the impact that has on this illness. Again, one of the things that we most often talk about this illness, it is what we call a stress vulnerability illness, and I will talk more about that, but that's why finding out this information about cortisol is going to be so crucial to helping these young people. Transitions are very, very difficult times for these young people, and it is when they are most vulnerable to the illness morphing into psychosis. So going from elementary school to middle school, going from middle school to high school to college, college to a job, or high school to the military, any of those transitions can certainly make a person more vulnerable to developing this. The neuroplasticity in the brain, again linked to the pruning process, is an environmental factor that can impact it. Again, stress and transitions either for the patient or their parents. So as the young person's stress level goes up, so will the intensity of their symptoms. But if you work with patients under 18, you need to be aware that as their parents' stress level goes up, they kind of absorb that like a sponge, and so it will also drive up the intensity of their prodromal symptoms. Stress management is huge when you're doing any kind of treatment with a prodromal patient, helping them not only to identify what are their stress triggers. You know, young people very rarely recognize that even possible things in your, positive things in your life could possibly drive up your stress. So, you know, you got a big award at school, so now the teachers expect more of you. Or, you know, you got a promotion in your job, so there's more pressure on you now to perform. So even a new baby being born into the family, while that's a very positive transition, it can be stress-producing. So it's really important to help these young people identify what are my stress triggers. And then they're usually oblivious to where they feel stress. So an important piece is helping them identify, where do I carry stress in my body? Do I get a headache? Do I get a tummy ache? Do I get muscle strain? How do I know I'm stressed? And then, of course, the last step is to help them decide what helps them relieve their stress, because all of us have different methods of dealing with stress. You know, somebody might want to go run for 5 miles. Somebody might want to do yoga or meditate. Somebody else might want to hit a heavy bag and punch it out. We all deal with stress differently, so it's very important to help our young patients navigate that whole path. And then the last environmental factor is substances. And again, I want to stress it's both illicit or illegal substances, street substances, you know, the K2s and the bath salts and all of that. But it also can be prescribed substances. And that's why accurate diagnosis is so important. So again, most vulnerable age period here is puberty. One of the things that impacts many adolescents is acne. One of the prescription drugs used to treat acne is something called Accutane. And in young people who have this vulnerability to psychosis, Accutane has been shown to increase their psychotic symptoms and to speed them along the path to full-blown psychosis. So we want to be very careful what these young people are prescribed. when we talk about the prodromal brain, if we review the existing literature for longitudinal structured and functioning imaging studies, we find very clearly that there is a vulnerability to psychosis associated with the deficits in the frontal, temporal, and cingulate regions. And CHR is accompanied by alterations in the functional brain activity during working memory processing. And this last bit is very exciting, and it is pretty recent in the last 2 years, that studies have demonstrated that the changes that occur in the brain in CHR patients, specifically a steeper rate of gray matter volume loss in the right superior frontal, middle frontal, and middle orbital frontal regions, cortical regions of the brain, play a role in psychosis pathophysiology. And the big piece of that is we now can say it is not likely due to antipsychotic drugs, which previously was a question. We weren't sure whether those changes were due simply to the progression of the illness or if perhaps it was due to some of the antipsychotic medications that were being used to treat it. But thanks to Dr. Cannon's work, we have lots of great information on that now. Results, what happens? So we know that these changes occur in the brain, but what are the results of that? How does it manifest itself? Well, there certainly are disturbances in attention, and those disturbances in attention are specifically an inability to filter out irrelevant information stimuli that leads to the patient feeling overwhelmed and resulting in information overload and really a total disruption in their ability to attend. They can have perceptual disturbances that may be visual, may be auditory, they can be tactile, they can be olfactory, and again, those alterations in their perception are going to impact their ability to attend, to be social, to interact with people. Their thought processes may change. The disturbances that occur there may be in the form of odd beliefs or magical thinking. This is where you'll get the mind reading, the being able to predict the future, that their thoughts are perhaps being broadcast out loud. There's just that interruption in their normal thought process. There are going to be disturbances in their speed of speech production. They know what they want to say in their head. It makes total sense. But when they try to get it out to ask the teacher a question or perhaps explain something to their parent, their synapses just aren't firing right and they can't get it out accurately. And vice versa, they might not be able to process what they're taking in as well. And so there'll be some interference with their ability to understand what other people are saying to them. And then there may be disturbances in their motor function that could include loss of spontaneous movements. Most often what we hear are problems in coordination or balance. So especially our young athletes will complain about that. I used to be, very coordinated and I'm a really good basketball player, and now I find I'm tripping over my feet more, and I don't understand why this is happening. I take good care of my body, I work out. Why is this happening to me? Let's look a little bit at the comorbidity of different mental health disorders in these CHR patients. 73% of patients with CHR. It was a meta-analysis that was done of CHR patients, and 73% of them had a comorbid axis 1 disorder in addition to their at-risk symptoms. 41% of those comorbid diagnoses were for a depressive disorder. About 15% of those comorbid diagnoses were for an anxiety disorder. And those comorbid diagnoses were associated with higher rates of suicidality, higher rates of self-harming behaviors, odd or disorganized behavior, avolition, apathy, and just an overall impaired global GAF, a reduced functioning. But they had absolutely no impact on the risk of transition to frank psychosis. And this led researchers to conclude that depressive and anxiety symptoms are likely to impact the ongoing psychopathology, global functioning, and overall longitudinal outcome of CHR patients, which again addresses the issue that the only reason for treating these patients isn't just to keep them from transitioning to psychosis, but to help mitigate some of the comorbid problems that are occurring. And there has recently been a review of the literature of substance use in the CHR population. There were 10 studies in total that were considered, and they looked at cannabis, alcohol, and nicotine especially. They were the most commonly used substances in this population, with incidences ranging from 33% to 54%. And only 2 of the 10 studies found a significant association between the use of substances and subsequent transition to psychosis. And it's very clear this wasn't everything that we need to know, but it certainly was a big first step in helping us understand substance use in this patient population. And certainly this is a big area where future research needs to be done. So again, transition to psychosis is such a big piece of what's discussed with early identification work, and partly because conversion rates in the at-risk or prodrome phase to psychosis range anywhere from a 20% conversion rate to a 40% conversion rate. It's a pretty decent spread, so we want to get a better handle on that. And one of the ways that we've been able to do that is with an algorithm that narrows things down. It looks at 5 particular features: deterioration in functioning, a history of substance abuse, high ratings on the SIPs or the CARMs in P1 and P2, and deficits in social impairment. So when 2 or 3 of those variables were combined, in addition specifically with meeting the COPS criteria of the SIPs, the positive predictive power jumped drastically from 68% to 80%. And, you know, in prevention, we don't get much better than that. So that was, again, thanks to Dr. Cannon and the Naples Consortium. It was very important research. There was another research group that found a positive predictive value of 80.80% when 1 or more predictive variables of poor functioning, long duration of symptoms, family history, high levels of depression, reduced attention, and then the subthreshold psychotic symptoms were taken into account. So we're starting to learn more about that total picture that we need to look at in terms of what's going on. And I think I inadvertently hit that. I'm so sorry. Okay. So one of the things that also has come out of that research that Ty Cannon did is the Cleveland Clinic is the organization that develops the risk calculators for heart disease and the risk calculators for cancer and things like that. And the Cleveland Clinic worked with this consortium to put together a risk calculator that is comparable in accuracy to both the one for heart disease and cancer to predict individual conversion risks. And it's really different. So like the SIPs or the CARMs, what those assessments do is let you know that as an individual, you are at an increased risk for developing psychosis when compared to the general population. What this risk factor does is it gives you your individual risk for converting to full-blown psychosis. So it's much more specific, and I find that with parents, they really can latch onto it and I think accept it easier. I think when we give the feedback to parents about, according to the SIPs, your child is in fact endorsing symptoms that alert us to the fact that they are at higher risk than the general population for developing a psychotic illness. However, having said that, I need you to understand that doesn't mean that they're definitively going to go on, to develop psychosis. The conversion rates range from 20 to 40%. It's kind of nebulous for parents. They want something more tangible that they can really hold on to. What is going to happen to my child? They probably have some preconceived notions about what a chronically psychotic patient looks like, and that can be very, very scary to them and frightening. Is that the road we're looking down? Is there nothing we can do to change this? And it's very important when we're working with these young people that we avoid that deterministic viewpoint of, being deemed at risk. Number one, their lifestyle choices certainly are going to impact their risk of conversion. Managing stress is going to help them. So we don't want them to say, oh, well, I have this vulnerability, so that's it. I'm definitely going to become psychotic, because we know, in fact, that is not true. And I think one of the reasons that this is still such a continuing area of research is because we need to be better at what are those self-protective things that, if you and I have the exact same DNA, besides my lifestyle choices, do I perhaps have some self-protective trait going on that my sibling doesn't have that prevents me from moving towards full psychosis? And we need to understand all that, and I think the risk calculator is really going to help that. And, when I first started playing with the risk calculator, I just said, well, what if I changed this? What if I added in another risk that they did have a first-degree relative with psychosis? Or what if I added this in or took that out? And I was amazed at the difference in the risk that made. And very, very clearly, the two crucial things that had the largest impact on whether people were at higher risk of conversion was their unusual thoughts and their suspiciousness. So those two items really are very strongly linked to how vulnerable they are to developing the illness. Now, the risk calculator does assume that a SIPS evaluation was given. That's the starting point for using the calculator. So right now, the risk calculator is most useful for clinicians with training in psychosis risk detection who are familiar with the SIPS and familiar with how you explain the results of the SIPS to patients and their parents so they can better understand the risk estimate and, can provide appropriate treatment recommendations based on the empirical data that we do know of what is most helpful for people in the at-risk phase. And just, to help parents be able to grasp this whole concept of risk better. And if you would like to learn more about the risk calculator and all of the information that I just mentioned, it is in that article published by Dr. Cannon and a number of other investigators. It was published in 2016, and it is called an individualized risk calculator for research in prodromal psychosis. And he really goes into great detail explaining how to use it, when it should be used, how effective it is, and when to be cautious about using it. So I've alluded to in several slides treatment with these young people, and I think it's really important that when you're assessing a young person for risk, in the back of your mind, you have that idea that we're not just doing this to label you or judge you. We're really doing this to try and figure out if there's anything we can do to help you feel better, to function better, have less distress, get a better quality of life. And it really is part of the continuum. And the American Psychiatric Association has released, it's actually quite a while ago now, their treatment guidelines for working with young people who are in this at-risk or prodromal state or developing a form of psychosis. And to start with, they feel it is essential to have a specialized assessment carried out to determine whether the person actually meets criteria for the ultra-risk phase. And so there are several specialized assessments that are available to clinicians to use. I am, of course, most familiar with the SIPS, but I also use the CARMS on a regular basis because in our Naples 3 study, we are looking for, we wanted to be sure that people across the world weren't diagnosing this phase differently. And so for everyone that we do a SIPS on in the Naples 3 study, we also do the CARMS on them to see if there is, in fact, agreement. Now, of course, the Naples 3 data, it's still an ongoing study, so it isn't available yet, but I think it will be very interesting to see if we do have that agreement in diagnosis across instruments. And more every day I'm learning, when I'm working with first episode clinics, I'll hear people say, well, we use this to determine whether they were prodromal or not, or we use this. So there's a lot of movement in this area of coming up with assessments I've even heard of some patient questionnaires, questionnaires that are given to patients to try to determine, excuse me, whether they're are developing a prodromal phase. Here at Prime, we do have a 12-question questionnaire, but its purpose is to help you determine whether a SIPS is warranted or not. The questionnaire doesn't define the prodromal phase. You know, a SIPS, I've done over 1,500 SIPS in my career, and even with all that practice, most SIPs still take me an hour. And so we certainly don't want to subject young people to an hour assessment unless we're pretty sure we're in the right ballpark. And so, you know, one of the things that I really stress with people is that before you do an assessment like the SIPS or the CARMS, that you do some type of pre-screening. And, you know, Rachel Loewy's PQB is out there. The Prime Clinics questionnaire is out there. There are many other ones. Or sites, individual sites, have come up with their own, so to speak, phone screen, where you ask pertinent questions for, in fact, I think for all of it, certainly for the SIPs, but for every assessment I've seen to try to predict the risk syndrome, there always has to be a minimum IQ of 70. 70 has traditionally been the IQ cutoff that defined mental retardation. And so while these are standardized assessments, the verbiage would not be standardized for someone with an IQ less than 70. So for example, here at the Prime Clinic, we do use a phone screen instead of a questionnaire. And one of the questions that I would go over with the referrer is there any evidence? Is this young person in special ed? Have they ever had IQ issues? To try and determine whether IQ is an issue before I bring them in for the assessment. And if I have questions, I might then ask the parent for some assistance in determining the IQ level. And again, it's not to discriminate against anybody, but it's just because I wouldn't want to bring that young person in, make them sit through an hour assessment that is going to be invalid because of their IQ issues. And, you know, other clinics, our clinic doesn't have a geographic catchment area, so that's not an issue for us. But some other clinics do have geographic catchment areas, so you might want to just get that out of the way right in your phone screen so that, you wouldn't bring the person in if they weren't going to be eligible. You know, you want to look, you might want to capture in that, is this something new or worsening, as opposed to long-standing and stable? Because, again, that's one of the contributing factors to whether or not this young person is really going to meet at-risk criteria or not. You know, and certainly you would want to rule out any medical conditions that perhaps might be a confound for diagnosing someone in the at-risk phase. So a seizure disorder, certain thyroid conditions, head injuries with loss of consciousness. There is certain criteria in the significance of the head injury that would make the evaluation invalid, or it could be not so much the severity of the head injury with loss of consciousness, but the number of head injuries with loss of consciousness. So a lot of young athletes, when they get beyond 5 concussions, it's just not, you're not going to be able to make a very valid diagnosis, because you always have to do the differential diagnosis, and it's not just differential for other mental health disorders, but it's also differential to reactions to medications, to physical conditions that may be driving this. And those types of things, if those things are present, it's not going to be worth putting that young person through the steps. So you can save yourself and them some time and stress by ruling that out in that phone screen stage of, doing this assessment. So that's really all part of having that specialized assessment, understanding how to pre-screen and then using a standardized assessment that will help you be accurate in diagnosing what their risks are. And then once you have diagnosed someone for being at a risk for psychosis, I mean, so, okay, why did we do that? You know, is it just to tell them, oh, you know, scare them, you're at higher risk? Of course not. Then the most important thing is to take a good clinical picture of where they are right now. Because without a thorough clinical picture, you really can't monitor their progression, their worsening. So there are many follow-up assessments that should be done once someone does meet criteria for an at-risk phase. So you would want to do things like the SCID or the KSADS and some depression and quality of life things, some neuropsych testing, some stress inventories. So there are other follow-up things that should happen for this young person. And the APA's recommendation for monitoring closely is monthly assessments. And the way that they came up with that is they based it on that original Australian research that showed that if they were there to intervene within those 28 days, that those young people had a better prognosis. So that is the American Psychiatric Association recommendation that you monitor monthly. Now, I know with the new Naples 3, people are going to question me about this because Naples 3 altered the following, the monitoring to every 2 months. But we always stress to the patient and their parent, if anything changes before your next visit, call us and we will bring you in immediately. The American Psychiatric Association's other treatment guideline is that you should treat coexisting conditions as appropriate. So we talked about the high incidence of depression and anxiety in these young people, and the American Psychiatric Association clearly states that they should receive treatment for those conditions, whether or not they progress to psychosis. And they also recommend psychosocial support and education, not only to the patient, but also to the family. So there are a lot of things that you can accomplish with psychoeducation that really helps reduce the stress in the family and in the patient, and that it helps them to deal with their symptoms better. And one of those things is just educating them that as they get stressed, when it's exam time, when they're under social stress, their symptoms might exacerbate. So they're prepared for it, and they have a plan for dealing with it, and they don't get blindsided. There's also ways to help the family learn how to communicate in ways that are more conducive to reducing the stress in a prodromal patient. So that all can be done even if you're not doing therapy or treatment, but those are all things that can be done as part of the feedback process for the assessment, the psychoeducation and the psychosocial support can all be done at that time. And the American Psychiatric Association also encourages everyone to recognize that youth meeting this at-risk criteria are, number one, help-seeking. So the SIPS or the CARMS is not an assessment that should be used on the general population. You know, we're not going to go into a pediatrician's office and do it on everybody. That's not how it's designed. It's designed for people who are reaching out because they are troubled or distressed or whatever, you know, by some mental health concerns. And then when we listen to what those mental health concerns are, we recognize that they could possibly be in this state. And because they are help-seeking, they are in need of care, whether or not they go on to develop a full psychotic disorder. They, you know, the American Psychiatric Association's wording was much stronger than mine. They really feel that it's unethical not to address these young patients' concerns in this pre-psychotic state. So just in summary of all of this, the prodromal patient is diagnosable, they're symptomatic, they're cognitively impaired, they're functionally impaired, treatment-seeking, and they are at risk for developing a more serious mental illness. One of the things I should have stressed is that the SIPS and the CARMS, they don't distinguish between affective psychosis and schizophrenia spectrum psychosis. It is just determining your risk for developing a future psychotic disorder. We know that at onset of this syndrome, there are measurable cognitive impairments, there's measurable gray matter volume loss, there's damaging social development losses, and diminished capacity to actively engage in treatment. So specifically, they find that young males who are in a pre-psychotic state usually enter the mental health field in the back of a police car or the back of an ambulance. That can be very stigmatizing. It can be very traumatizing. And again, one of the symptoms that we most often see in the prodrome is some sense of suspiciousness or paranoia. And when a person is suspicious or paranoid, they're less likely to be an active participant in their treatment plan. Prodromes recognize what I'm experiencing is different, it's odd, it's unusual. They want help. They are more likely to be an active participant in their treatment plan, and as such, the treatment plan has a much better chance of being effective. And the presence and the duration of prodromal symptoms may predict whether the outcome in schizophrenia, that is that the long duration of prodromal symptoms may be indicative of a poor prognosis, similar to the information on a long DUP is equated with a worse prognosis. Prodromal patients are, I guess I just can't stress enough, they are help-seeking. They want help. They want us to try and help them to function better and feel better. And to me, that's the take-home message of this. I'm not 100% convinced we can prevent psychosis. I'm hopeful that we can, but I certainly have seen in my 19 years here that we can help mitigate their level of distress and improve their quality of life. And again, just my 2 cents is that I think a direction for future research is establishing evidence-based treatment for this population and exploring supportive environmental factors and internal gifts or talents that might help reduce the risk. So that's the end of the formal presentation.
Okay, it looks like we have a few minutes to do a Q&A session, and we've had a ton of really great questions come in via the chat box. I just wanted to note that since we did have so many questions come in within the about 13 minutes that we have left, we're not going to be able to get to every question, and I know Dr. Walsh did elaborate after some questions were put in the public chat. However, both Dr. Walsh and Ryan are going to have a copy of these questions, and they can follow up individually via email for questions that might be very specific or that are outside our purview of being able to answer today. So Dr. Walsh, to start off, Geneva, at the beginning of the presentation, mentioned that she has a grandson that has been setting fires and wanted to know if that would be considered one of the early warning signs.
Fire setting is not one of the typically associated prodromal symptoms. Now, that doesn't mean it couldn't be, but it isn't one of the ones that we usually speak about.
Okay. In a similar vein, Kim mentioned that she had a case where theft was involved, and it was a pretty significant theft, but the individual that committed the act didn't take on any accountability for the consequences of this act. So not showing remorse or offering an apology, would that be considered one of the symptoms as well, or no?
Okay, so that's a very, very interesting question. Again, part of the Naples 3 consortium, we're using the SAVRI to look at, offenders, people, nonviolent offending as well as violent offending, and what's the incidence and what does it have to say about this whole syndrome. And so we don't have that information now. But in a case like that, if that were my patient, when I talked about the follow-up assessments that you would do with these young people, I would do something that looks at sociopathy with that young person.
Okay. And Sue has a question about some of the factors that you talked about and how much chemical imbalance might initiate this syndrome, I guess, compared to other risk factors, genetic or hormonal or environmental.
So how much a chemical imbalance, would that, you mean in the calculator, would that be a higher thing that would increase your risk?
I think so, and Sue, feel free to chime in the chat if you want to clarify on that question a little bit more.
Okay, so the chemical imbalance, again, is not the top two. That would be, the top two definitively are the P1 and P2 symptoms, followed very quickly after that by family history. So it wouldn't be in the top three.
Okay. Stephen asked, you talked a little bit about the stress vulnerability model, and he wants to know what role trauma plays in that model.
Oh, thank you so much for bringing that up. That's my bad that I didn't mention it. Trauma certainly is a stressor that would have a huge impact on that vulnerability. Even neglect, we see young people who had failure to thrive because they were neglected in the first 2 years. That certainly increases their risk. So, yes, trauma does play a role in that risk.
Okay. Summer noted, and just like you noted when you were going over the early warning signs, that there's some overlap with some other mental health diagnoses. You pointed out, in particular, overlap with autism spectrum disorder, but she noted that there's some overlap with depressive symptoms as well. She wants to know, are there any early warning signs that are specifically unique to psychosis, to this mental health issue that you wouldn't find overlapping with depression?
Yeah, so again, when you think of schizophrenia or psychosis and you look at the two sides of the illness, the positive symptoms, the addition of a thought disorder, hallucinations, delusions, bizarre behavior, those positive symptoms are very specifically linked to psychosis. Whereas, the other side of schizophrenia or psychosis, the negative signs, where you see the lack of enjoyment, the lack of motivation, all of those can very much, that's one of the problems with young people. If they present first with the negative symptoms, they're very oftenly thought to have depression or even oppositional defiant disorder, because the negative symptoms of psychosis do look more like depression than psychosis. But the positive symptoms are very specific to psychosis.
Thank you. Amanda has an interesting question. She works with vulnerable youth populations and says that she's seen more than one case where a child appeared to fabricate symptoms positive for psychosis in order to avoid consequences of other behaviors, and wants to know what recommendations can you offer for distinguishing true positive symptoms of psychosis from falsified symptoms?
That's an excellent question. And when the SIPS was originally authored, that was a big part, How do we deal with over-endorsers? How do we deal with, I'm going to say it was because that, so I don't get in trouble. And when you're certified in using the SIPS, one of the things that is stressed and you learn is that you never, ever lead the patient anywhere. You use that whole Socratic way of questioning a person. Has this ever happened? And they say yes. And you say, how so? Can you tell me about that? And people who are making it up are not going to be able to tell you the essence, the true essence of their symptom. They're just going to say, oh, I hurt my brother because, I had a bad thought or something like that. But they're not going to be able to get into the specifics of it with you, that can describe that true positive symptom or symptom that alerts us to being at risk.
Okay. Catherine wants to know if you have any thoughts about the impact of psychostimulant medications such as Adderall on early psychosis.
Oh boy, I was praying nobody was going to ask me this. And the reason is the information is so controversial on this right now. The original studies were that amphetamine is an amphetamine, whether it's a street amphetamine or a prescribed amphetamine, it's still the same form of action and is going to make their symptoms worse. Now there are some newer studies that are saying if the amphetamine is prescribed for the right reason and is effective in treating that problem, it might reduce their stress and therefore could be helpful. So I guess my answer to you is the jury's still out on that one.
So Ian had a question regarding the attribution criterion in SIPS. It seems the better the psychopathologist you are, the more likely you can formulate someone's attenuated psychotic symptoms as arising as part of another non-psychotic disorder as opposed to representing a psychosis-risk syndrome, especially given that most young people presenting with a risk syndrome do have another disorder. Do you have any comments or thoughts on this?
So an important part of training, and Ryan, you might want to jump in here, but a very important part of your training and learning to use these assessments is all around differential diagnosis. So I do think there has to be a certain level of expertise and understanding of the various different mental disorders and how they manifest. I don't know, Ryan, would you like to address that more?
Yeah, I hope my
Hold
audio
on
is a
one
little bit
second. I'm going to
better.
unmute
I apologize that I was
if
having
he
some
wants to
difficulties.
chime in.
No, I completely agree that you wouldn't want to go into any, you know, assessment of someone with a potential psychosis-risk syndrome without really solid understanding of differential diagnosis and treatment recommendations for a wide range of conditions, just given the crossover and subtleties that can happen with this particular condition. So yeah, absolutely, good knowledge of a wide range of psychiatric disorders and training and assessing for them is absolutely necessary.
And Ryan, that sort of actually goes to a question Tamara brought up about what training is needed for people to administer SIPs. And you talked a little bit about what cautions you would make regarding it as well.
Yeah, so I mean, there certainly is a basic level. There isn't a particular, like, you don't have to be master's level, you don't have to be PhD level, but there has to be a combination of experience with mental health disorders and using diagnostic instruments. And, you do have to be certified in the use of the assessment. And of course, we always recommend ongoing supervision for at least 6 months, but we prefer a year after you start using the assessment. And I have to be honest with you, even myself, even though I've been doing this for so long, I will still do inter-rater reliability with other groups and stuff, because you do need to be concerned about rater drift. The thing about the SIPs and even the CARMs, you're rating the young person's symptoms against the item. You're not rating them against the general population or even against an ill population. You can't say to yourself, oh, the kid I saw last week was much worse than this, so I'll give them a lower rating. You can't do that. Each item is individual. It's what they're reporting or what you see against the item. So the training is really crucial in helping you to be good at this.
Excellent. All right. Well, we are just about out of time. We want to thank everyone for your participation. One thing that I did want to note is that we did put a copy of a link to the guidelines in the public chat box that you can click on. We're also going to put in the chat box a link to join PEPNet, and I'm going to have Ryan
Yeah,
talk a
please
little bit about what
consider
PEPNet
joining
is.
PEPNet, which is a collaboration of many early psychosis providers kind of across the country, where we're sharing ideas and talking about everything that came up on this webinar, amongst just what's kind of in best practices for individuals in early psychosis programs and clinicians, participants that are part of early psychosis programs. So a nice collaborative of professionals around the country that are doing the same work or similar work that you all are doing.
Excellent. All right, and we want to thank Dr. Walsh for providing time to provide this webinar to everyone. And we did record the webinar, and we will be sharing out that information once the recording is posted to the TA Network's YouTube channel. And finally, Ryan and or Dr. Walsh will follow up with any of the additional questions that were posted in the chat. Hope you have a great day, and thanks for joining us.
Thanks, everybody.